Hello friends, today we will discuss about a very important topic named pulmonary thromboembolism. So this is a thrombi in the pulmonary vasculature. As you can see here, this is a thrombi in the pulmonary vasculature and the source of thrombi is the deep vein thrombosis which is called as DVT. So the most common site of DVT is deep veins of calf, alright? The most common site of DVT is the deep veins of calves, and the most common source of embolism is mainly the popliteal vein, and after that the femoral veins. And this is this pulmonary thromboembolism. All right. So in pregnancy also there is embolism in the pelvic veins. Thrombi and microthrombi migrate, all right, and these thrombi and microthrombi migrate from the systemic circulation, and these thrombi and microthrombi migrate from the systemic circulation to the pulmonary vasculature. One thing which is very important in this is the deep veins of lower limb are more affected than the upper limbs. Okay, so this is also an important thing we must remember. Now we'll talk about the risk factors, the risks of uh, pulmonary thromboembolism. The very important one we'll talk about only, like you must understand the genetic is the most common, all right? So we consider the genetic ones are the most common. And what are the examples? One is factor 5 Leiden mutation. The another example is protein C and protein S deficiency. And another example is antithrombin 3 deficiency. Okay. Now, these are the things which we have to remember in the genetic risk factors of pulmonary thromboembolism. What we did read was factor 5 Leiden mutation, protein C and protein S deficiency, and antithrombin 3 deficiency. The other one which I want to mention is malignancy. This is another cause. And very important cause inside malignancy is adenocarcinoma. Okay. Then we'll go to the obstetric causes. Obstetric causes. Now, what are the obstetric causes? Obstetric causes are like pregnancy, puerperium. Okay. Then we go to nephrotic syndrome. Nephrotic syndrome is also a risk factor of pulmonary thromboembolism. In nephrotic syndrome, there is membranous nephropathy, which causes pulmonary thromboembolism. There are various other causes also, like risk factors like COPD, congestive heart failure, and even after surgeries, with immobilization of for more than 4 days, thromboembolism can occur. And there is one syndrome, if you guys can guess, it is named as EPLA syndrome. EPLA syndrome, and there are myeloproliferative disorders like paroxysmal nocturnal hemoglobinuria. So this is also a risk factor for pulmonary thromboembolism. Now I'll discuss about the massive pulmonary embolism. So first of all, let's discuss about massive PE, pulmonary embolism. The pulmonary embolism with sustained hypotension and bradycardia, which is profound, right? So, pulmonary embolism with sustained hypotension and or bradycardia. If the BP is low or the heart rate is low and there is a profound hypotension and bradycardia that is less than 40%, this can lead to pulmonary embolism. So first of all, we will discuss submassive pulmonary embolism. PE without shock. That means without hypotension. So the pulmonary embolism without hypotension or shock is submassive pulmonary embolism. So one thing which we need to remember is the features of right ventricular dysfunction. The features of right ventricular dysfunction, and how will you diagnose these features of right ventricular dysfunction? By echocardiography, right? The other thing you must see is in elevated beta natriuretic peptide levels, or you may see myocardial necrosis. And what indicates this are the elevated levels of TROP-I or TROP-T. So these levels will be elevated. There will be elevation of these levels. Now there is occlusion. All right, occlusion in the first order main pulmonary artery, and this will be symptomatic. The patient will be symptomatic. So there will be 70% occlusion or more, and there will be RV failure. That is, there will be hypotension in the patient. The right ventricular failure or hypotension will be there, as 70% or more has been occluded. So occlusion will be there in the first order main pulmonary artery, and this will be symptomatic. All right, so what will the patient will have? What will the patient have? The patient will have, as we have told, there will be symptoms. So the patient will have hypoxia. And this hypoxia will stimulate the vagus. That will result in bradycardia. And there is distal lodging of emboli, that is 20%. This is pulmonary infarction. So we also count a dead space ventilation. We see the dead space ventilation, and this is V by P, which is equal to infinity. So now the second thing which we come to is the symptoms. Okay, now we'll talk about the symptoms of pulmonary embolism. So let's talk about the symptoms of PE. What are the symptoms of PE? First of all, it is acute onset dyspnea. Dyspnea means breathlessness. There may be or may not be DVT. There may be deep vein thrombosis or not, but there will be an acute onset dyspnea. There is pleuritic chest pain, and this is the second most common symptom. All right, the first one was acute onset dyspnea. Okay, and the second most common symptom was pleuritic chest pain. This is the second most common symptom, pleuritic chest pain. So acute onset DVT and pleuritic chest pain. Now, after that, the patient may also complain of cough with hemoptysis. So the patient has cough as well as hemoptysis, that is blood in the sputum. In around 10% of the patients of pulmonary embolism, we can see this problem also. But the main important thing that we have to remember is acute onset of the dyspnea and the pleuritic type of chest pain. This is very, very important. Others, the findings that we can see in less than 10% patients will also have a crackles or decreased breath sounds. But the other findings which we can see easily are tachypnea, tachycardia. All right, the heart rate will be increased, but the chest will be clear. But in less than 10% of the cases, you can hear the crackles, you can hear the decreased breath sounds. All right. Now, as we discussed in this one, the first symptom was acute onset of dyspnea, and the acute onset of the dyspnea will be within seconds. Okay, so this acute onset will be within seconds, and the chest pain is seen in less than 20% of the patients. And why is this seen? Because of the distal lodging of the emboli. So there is a distal lodging of the emboli. That is why you can see the symptoms. All right. Other things which we can measure is the BP of the patient, and the patient will be in shock. Third heart sound can be heard, and you should see the JVP, and as there will be no JVP because of the right ventricular failure. All right, you can estimate the right ventricular failure in this. Now, very important thing is the patient will have hypoxemia. There may be respiratory alkalosis in the patient of PE. There may be widening of alveolar gradient, or there may be or arterial gradient. Okay, and alveoli and the arterial gradient both will be widened. The difference between the concentration will be more between the alveolus and the artery. Okay, and the tachycardia will be more than transient STT changes. Now we'll come to the ECG findings of this patient. Now, in the ECG findings, very important is tachycardia, which is the most common finding in these patients, and there are transient STT changes, right? S wave, you can see in the lead 1. Q wave, the changes can be seen in the Q wave on lead 3, and T wave inversion could be seen in lead 3. Okay, now we have to rule out certain possibilities. Before this, we have to rule out certain possibilities. what we have to rule out, RV strain. If there is any right ventricular strain, you have to rule out. Or we can see one more important thing which we have to estimate is if there is a T wave inversion in from V1 to V4 in the ECG, then there is a bad prognosis. All right. Let's move to another diagnosis, that is X-rays. In the most cases, the X-ray will be normal, but on X-ray, typically these patients will show long linear basal bands of atelectasis. There are pleural based opacities, and these are called as Hampton's hump. This is very important to remember for exams. Hampton's hump. These are the pleural based opacities. Enlarged right descending pulmonary artery, and this is also a sign named as Pallas sign. Enlarged right descending pulmonary artery. There is focal oligemia of right lower lung. This is known as Westermarck sign. Okay. And the last very important sign is prominent central pulmonary artery. Prominent central pulmonary artery, and this sign is known as Fleischner sign. Okay. So these were the signs. So in the short, I want to mention on the X-ray that mostly the X-ray is normal in most of the cases, but there are some in some patients there is long linear band of atelectasis. There are pleural based opacities which are called as Hampton's hump. There is an enlarged right descending pulmonary artery which is called as Pallas sign. There is focal oligemia of the right lower lung which is called as Westermarck sign. And there is a prominent central pulmonary artery which is called as Fleischner sign. Now we come to a diagnostic criteria on which we'll give the scoring, which basically is a scoring criteria for the pulmonary embolism cases, which is very important for the grade of pulmonary embolism. And this is called as Wells score. What is Wells score? First of all, I will write here the low probability, and here I will write moderate to or high probability, right? Low probability will get low score, and okay, and this will get the high score. Very important thing. First of all, in this we see the D dimer. Okay. And it will be less than 500 nanogram per ml in the low probability or low score patients. Okay. And in the moderate or high score, high probability, the D dimer is not required. Instead of this, there is helical CT pulmonary angiogram, and this is the investigation of choice in the moderate to high score patients. Helical CT pulmonary angiogram. If the patient has low score, that means he has less chances and the score is low, then the D dimer must be done and it will be less than 500 nanogram per ml. If the patient has a higher probability of this, then helical CT pulmonary angiogram should be done. And this is the investigation of choice if the patient gets the high score. So, in the patients of low probability, the chances of pulmonary thromboembolism is unlikely in the well score. Uh, so we'll only do the D dimers in the well score, that we have to remember, and the chances of pulmonary thromboembolism are unlikely. In the patients with moderate to higher uh, probability, D dimer is not required, helical CT pulmonary angiogram is done, and this is the investigation of choice. And in pregnancy patients, there is a ventilation perfusion scan is done. All right, ventilation perfusion scan must be done. For this, we'll also see a very important sign which is called as polo mint sign. Very important sign, polo mint sign. So, in this sign, there is a thin rim of contrast which persists around the central filling defects due to a thrombus. All right. So, there will be a thin rim of contrast. Okay. Thin rim of contrast. And this thin rim of contrast in the polo mint sign, there will be thin rim of the contrast. Okay, so this is a central filling. Suppose this is a thrombus and there will be a thin, this is the thin rim of contrast. So this is polo mint sign, and this is very important to identify if there is a thrombus or not, and to see if there is a central filling. All right, there is one more sign which is called as McCannell's sign. This is called as McCannell sign. McCannell sign, there is right ventricle hypokinesia. On echo we can see this sign. Very important sign. There is, this is called as McCannell's sign. Very important sign, must remember, as this is a very important finding and this is seen on echocardiogram and echocardiography, and there is right ventricular hypokinesia. Now, what is the management of pulmonary embolism? How will you manage a case of pulmonary embolism? Now, first of all, we have to understand if the embolus is non-massive. If it is non-massive, then you can start anticoagulant. Okay, at the earliest. So first of all, you can start the anticoagulant at the earliest. You can start an anticoagulant in the non-massive pulmonary embolism. Second thing you can do is unfractionated heparin. Okay, unfractionated heparin can be used, or low molecular weight heparin is preferred. All right, this is preferred. Okay, and what is the dose 1 milligram per kilogram. Okay, S subcut PD. Okay, so this is very important. Unfractionated heparin or low molecular weight is very much preferred in these cases, in non-massive pulmonary embolism cases, and the dose is 1 milligram per kilogram subcutaneous or twice. Overlap with warfarin to maintain INR. Okay, and what is the INR you have to maintain? It will be 2 to 3. Very, very important. So from the beginning, let's see the treatment. If you see a non-massive pulmonary embolism, then start anticoagulant at the earliest. Unfractionated heparin or low molecular weight heparin is the preferred one. Low molecular weight heparin is much preferred one. The dose is 1 milligram per kilogram subcutaneously, BD, twice daily. Overlap with warfarin to maintain the INR at 2 to 3 in case of contraindications. Now, very important thing is, if this is contraindicated, if the anticoagulants are contraindicated, you cannot use the anticoagulants, they are contraindicated, then what you will give? There is nothing to give. You have to put an IVC filter. You have to put an inferior vena cava filter. Alright. So this was about non-massive thromboembolism. Now let's go to submassive or massive thromboembolism. Very important thing in these are the BP is low. Okay, and there will be very low BP. The patient may go in shock. So there is an extensive clot burden. All right, so there will be, in the case of extensive clot burden, you have to thrombolize the patient. So thrombolysis is one of the options. Thrombolysis, and this is the indication also if there is a extensive clot burden, like in massive thromboembolism, you have to thrombolize the patient. And the thrombolysis are of two types. There is a medical thrombolysis, and how will you do the medical thrombolysis? We'll give LT+, 100 mg IV for 2 hours. So you have to give LT+, which will be 100 mg IV